ongoing symptoms, either nausea, severe pain, maybe they become bradycardic, because it absolutely can cause that. Maybe they become hypovolemic. It's a huge medical emergency, so it can affect everything in your body. They need a cath lab and intensive care, so it's important to try, like I said, early recognition of this, and then transport to the hospital and get everything you can done en route, save some time. So serial 12 leads and vitals should be monitored until care is transferred. So then AFib. AFib is going to be also dependent on the rate, symptoms, and should be cautious on the time frame of symptoms, because if the patient's been experiencing this for a few days, then because AFib does increase your risk of clots, sometimes if you slow the rate down, it can throw a clot. So just be cautious. So it may include cardizine, which is a medication or is a calcium channel blocker medication that may consist in controlling the heart rate. It can cause a multitude of symptoms, either blood pressure abnormalities, altered mental status, weakness, shortness of breath, heart palpitations. So synchronized cardioversion, which is a procedure that sends electrical shocks to the heart, may be needed in a pre-hospital setting in cases with severe symptoms to help stabilize the patient. So then you're going to continue to monitor vitals and EKGs to make sure there's no severe changes. It's important in these patients to know if they've had AFib before, if they've never had it, the last time they had it, was it controlled with medication, or did they have to be cardioverted at the hospital? That kind of leads you to believe that medications may not be effective for this patient. SVT, supraventricular tachycardia. So this treatment, again, varies by symptoms. It is always a heart rate over 150. So typically, you start with a vagal maneuver, which I always tell people to push down like they're going to the bathroom or blow through a straw. So that should be the first treatment you should do. It's low risk. It probably won't cause any complications. They can do that while you're setting up everything else. So adenosine is the next medication that can be used. Be an IV rapid push. It has to go quickly because it has to get to that heart quickly. So the better the IV you can get closer to a heart, the better. So it works by causing a heart block in the AV node. It may cause the patient to go in transient asystole for a very short time. So if you've ever given this, you have that pucker effect. You give it, the patient might start having swelling in the chest, and if you watch their EKG, they'll go in asystole for a minute, or probably about 6 to 10 seconds normally. It's scary the first time you do it. Most times they come back out of it. So you should always place your pads on your patient, because there's that 1% chance that they might not come out of it. And your vitals should be reassessed multiple times. And then synchronized cardioversion is the preferred treatment in severe cases when patient symptoms are really bad to begin with or they worsen throughout treatment. So this is a conversion using adenosine. I'll show you real quickly.
Hey, I created this beautiful logo for my bike shop with Wix logo maker.
Stand by.
Go to Wix.com.
This is when they actually give it. And notice how they're giving the medication with a saline bolus. That is to help it get to the heart quicker. This, in just a second, you'll notice the rhythm begin to change. See? And then you notice how it flatlined for just a second, and then it went back into a slower rhythm. They're in the 140s, 120s right now. So in this case it worked, and a lot of times you need multiple doses before it works, and sometimes it just won't work at all. Notice it's starting to go back up a little bit, but they're out of SVT because they're under 150. And they're stable because their blood pressure was 115/76. So that's a good indication that you can start with medical or medicine first. Alright, moving on. So VTAC. That is the first line treatment for VTAC is determined by symptom severity. I keep preaching that. So first medication is amiodarone infused at 150 milligrams. That's with a pulse. If rhythm persists, lidocaine 1 milligram may be considered. If the symptoms continue to persist or worsen, cardioversion should be considered. Cardioversion may be synchronized or unsynchronized. It is determined on if the VTAC is regular or monomorphic like we talked about earlier, or irregular polymorphic. In monomorphic, you will always try and do synchronized cardioversion. In polymorphic, you will always do unsynchronized cardioversion. Pads should be placed. Manage other symptoms as they come along. Monitor your 12 leads. So this will be cardioversion along with VTAC. Notice that heart rate. Notice how the complexes are wide. In just a second, you'll see a rhythm change. You'll hear the monitor charge up. And right there is where the shock was delivered. And now it will go back into a different rhythm. It may need a few different times, but it all varies. Alright. So VFib. VFib again, your patient's in cardiac arrest. CPR, that should be the first thing you do. You hop right on that chest as soon as you recognize you're in VFib. The AED should be placed if you do not have access to a manual defibrillator, which if you're on an ambulance, you probably should. So manual defib is every 2 minutes at different joule settings, depending on what your local protocol is. Epinephrine, IV push through an IO, or IV, whatever you have. Amio 300 milligrams. Notice that dosage is different because you do not have a pulse, and that is a straight push. It is not infused through a drip. Our protocol states we can only go up to a 450 milligrams before we go to lidocaine. In refractory VFib, that means amiodarone and electrical therapy has not worked in breaking it yet. You may need vector changes, which is just you place normal pads are up here. You may place your pads up there or on the back. It kind of hits the heart with electrical therapy in a different way. Fluid therapy, and then start wondering about your underlying causes. Asystole. So asystole, again, CPR. Epinephrine per your local protocol, saline boluses, and underlying causes. Not really many medications you can give in asystole, or anything you can do besides CPR and wait it out and try and figure out the underlying cause. Again, like we said, this is probably your rhythm after a few other rhythms. Either we didn't get there in time for it, or we've already tried to treat that. Poor prognosis with this. So what are some ways EMS providers improve patient outcomes? So, early recognition is an important factor to ensure a positive outcome for patients experiencing cardiovascular emergency. Stand by. So, due to on-scene 12 leads and early cath lab activation, time to reperfusion and mortality rates have declined. And reperfusion is just when the heart receives the oxygen-rich blood again. Direct transport to PCI centers who can perform the emergency catheterizations have improved patient outcomes. Treatment center at the cardiac center can stabilize the patient, improve outcomes, and transmission of 12 leads allows for the hospital physicians to be better prepared for the patient and kind of know what they're working with better. So why does a hospital designation matter? Sometimes it isn't common knowledge for the general public that all hospitals aren't the same. Not all hospitals are equipped to handle certain types of emergencies, and in the case of a cardiovascular emergency, transport to a PCI center is important to their outcome, as transport to a non-PCI center can delay care. Always consider where a patient received their prior cardiac-related treatments, and consider all symptoms and medications and patient history when determining a hospital. And by that, with the PCI center means, we have 2 PCI centers in my district, or close to me, versus our local hospitals that can do routine catheterizations, but they cannot do emergency catheterizations. Sometimes people drive themselves to the hospital, so then they have the delay of going to the hospital, the waiting room. I mean, if you're having chest pain, you normally get sent right back. But then the 12 leads, then those physicians have to recognize that this patient's having a STEMI. They then have to get medications and then transfer either via critical care ambulance and 911 ambulance, or however that hospital chooses to transfer to a PCI center. So it does delay care significantly versus calling EMS to early recognition and then quick transport straight to the PCI center. Time is muscle. The longer the patient's infarcting, the prognosis is poor. So fun and not so fun facts. There is approximately 356,000 out of hospital cardiac arrests each year. 90% of patients do not survive. And as of 2016 per the AHA, 40.7% of laypersons initiated CPR in a cardiac arrest event, but only 5.7% used AEDs, which kind of speaks on the fact that CPR should be taught better. We should have that in more schools. You don't have to be certified to do it. It doesn't matter. You just need to do it. And I think a lot of the time, people still have the idea that to do proper CPR is you have to do the mouth to mouth, and that's not being taught anymore. So that education needs to be spread around so our outcomes can be better. And AEDs are essential. They need to be in every public space. They make a huge difference. So out of hospital survival in a cardiac arrest situation drops from 5 to 10% every minute without CPR. So again, that speaks, we need to get better at teaching people CPR and understand that they need how to do it and that they can do it. Because cardiovascular disease is a single leading cause of death in the United States. And that includes vascular diseases and heart diseases. And then 2 million people are diagnosed with acute cardiac syndrome each year. 1.5 million will experience an MI. And then of those, 500,000 will die. And 250,000 of those will die within the first hour of the onset of symptoms. So, in summary, we've talked about what are some type of cardiac emergencies, what are some symptoms that you may expect in these patients, how do these patients vary, and what determines their proper treatments. What is the difference between a 3-lead and a 12-lead? How does the EMS change patient outcomes? We've discussed a lot of this today. I know I harped on severity of symptoms because that's so important, especially in a pre-hospital setting. It's important to remember history, especially if they have a known hospital that they've been treated at before, and try and go to that hospital because it improves their outcomes. Early recognition in the EMS setting is essential, and a cath lab education is essential. So those are just super important things to remember when a cardiac emergencies. I know we've covered a lot from the BLS to the ALS side. But other than that, if you have any questions, I will attach an evaluation sheet to see if you feel like you learned anything today, or if I covered everything too fast. But other than that, that's my patient, and thank you very much.